Welcome to the Understanding Healthcare podcast with Zach Cantor. Today I have my guest, Caroline Loy, and we're going to be talking today about plan design. Caroline, welcome to the show.
Thank you, Zach. Happy to be here.
Thought we could just dive right in and maybe just start with what is plan design. If you're coming in off the street and you don't really know much about healthcare, how would you start by describing what plan design is?
Yeah, absolutely. I mean, if you think of health insurance kind of as a subscription of sorts, plan design is what you might think of as the fine print or like the contract that you have for that subscription, right? It's the rule book for what determines what you'll pay. And like most insurances that you go out to the market to buy, you often have this kind of predefined set of rule book. I think what's unique about healthcare is that you're using that insurance much more than you would, or at least you hope to use it more than you would your car insurance or your house insurance, right? Um, the that kind of the plan design, what it does is it decides what your things like your deductible, your copay, your out-of-pocket max, which are terms that I'm sure we'll dive in over the course of this. But really, it's kind of what you as a patient can expect to pay when you get care, right? And then more specifically, it also defines what will be covered. And so much like when you go shopping for something, the plan design is what you have access to, very simply.
So super helpful. And so, to talk about the parties involved here, when you say you, it sounds like you're talking about the member or the patient. So when I go into my doctor or dentist's office or go into the hospital in an ambulance, this is kind of dictates what I'm going to end up paying. And it sounds like probably the employer is involved in this as well. And then there's another party, which is the provider. How does the kind of provider fit into the piece here? Is that handled a different way than what we're talking about? Is this mostly between the employer, the employee, and the insurance company?
Totally. I think maybe the best place to start is like who decides the plan design, right? And then we can kind of see how the provider fits into it. But the plan design is typically decided either by the insurance company or increasingly kind of in the self-funded market by employers who are the ones that are kind of taking on the risk of the plan. Um,
Can you
and
just take a step back and
yeah,
explain what do we mean when we say self-funded? So if I'm coming in off the street, there's probably two models that I'm familiar with. One is I buy individual insurance directly from an insurance company or on a marketplace, or two, I just get a plan through my employer. I don't really know how that all works.
yeah, exactly. So when you get a plan through your employer, there's kind of typically to simplify things two ways that your employer might offer that insurance. And the first is what we call fully funded, which is your employer says, "Hey, I have these 100 employees. I go to Cigna, and I would like you to cover these 100 employees. How much is that going to cost me?" Cigna comes back with a quote, and then your employer is the one kind of paying that premium, and often you're paying kind of a share of that, right? Which is the experience that most employees have, right? They see that kind of premium number and that's what they're familiar with. Um, for self-funding, it to an employee will look and feel almost identical to what a fully insured plan will feel like. But the only difference is that your employer is actually the one subsidizing your care. And what I mean by that is that your employer actually has a dedicated bank account from which they are paying out your medical expenses. And so instead of going to a traditional carrier and saying, "How can you cover my employees?" they're saying, "I'm going to allocate a certain amount of money to provide medical spend to my employees," right? And so when we think about plan design, the person who designs the plan is the person taking on the risk of that coverage. And so, in the traditional world, in the world that we typically think of as insurance, it's the insurer itself. But in health insurance, more and more employers are actually taking on that role of being the risk bearers. And so they, because they're taking on that financial risk, get the added benefit of getting to decide how things will be covered and to protect themselves in many ways.
And well, is it typically, are there certain profiles of employers that might choose to do their own plan design to be, self-funded and versus fully insured?
Yeah, I mean, typically we think of it as the larger the employee, the more like the employer, the more likely they are to pick self-funding. And that's because they can they find themselves in a position to take on more financial risk. So smaller companies typically aren't going to set aside this money.
Is it when you think about why they would do this, is it primarily and solely financial, or is it, what component of this for the employer is financial versus other?
Yeah, I think it's a great question. So for the employer, there is an element of a big element of it is financial, but there is also an element of it which is, talent, strategy, and differentiation, right? And so when you combine those two, employers now have a harder time competing on salary alone. And so benefit strategy can be a big lever for them in terms of getting talent, especially in very competitive markets such as, the Bay Area, New York, et cetera. And so the reality is, it's still predominantly today financial, the decision. When you think of the traditional insurance model, when you receive a quote, when you, the employer, receive a quote from the carrier, that quote is based on a risk assessment that those actuaries have run, right? And you're kind of on that cost curve deciding. They place you in the middle of that cost curve. And if your population is healthier that year, the carrier is the one that will benefit. And if, of course, your population incurs more claims, then the carrier obviously takes on that burden. As employers become more uh, more financially stable, they want to be able to benefit from that kind of gain financially. And so they do that by plan design, but also by adding extra levers, which are typically some of these point solutions or other kind of chronic disease care management solutions, et cetera.
When you talk about the benefit for employees in terms of being able to be, the employers should be more competitive with what they're offering. I mean, I would imagine that, being able to offer a $10 instead of a $20 copay is not going to make the difference between someone joining Google or not joining Google. Can you talk about what some of those levers are that someone might pull?
Yeah, you're spot on. The copay itself might not make a difference, but the type of plans that you offer will make a difference, right? And the premiums that you're offering alongside those plans. And so, typically, what you see some of the big differentiators. So, network is a massive component of that differentiation. And what I mean by network is to a patient, to an employee, the network dictates who you can go see, what providers you can go see. And as you know, the employable population nowadays is switching jobs more and more. What they want is consistency in terms of the provider, right? And so if they're switching to a new company, they want to know that the provider that they've been seeing for the last 20 years will still be in network. That's a key component. But then there's also some of these kind of nice to have benefits. And that's going to be things like your fertility coverage, your chronic disease coverage. You start seeing employers add more mental health benefits, right? And more kind of coverage for the known gaps in the US healthcare market. And that can be, I know fertility, for example, is one people ask about it when they join companies. Is that something that's covered? And so more and more employers are trying to get kind of proactively identifying what are these big ticket items that will actually sway a person one way or another to join our company.
And when you look at something like fertility, is that something, you can't just go buy an off the shelf Cigna plan as an employer and then layer in fertility benefits somehow? You then kind of have to pull the escape hatch and go all the way to your own plan design.
There are definitely options to do it kind of in the more traditional, the fully insured way. But those options often come at a very high premium per employee, right? And so often you're trying to add these benefits. It's not going to be the large majority of your population that's actually getting that care. And so it becomes much more beneficial to you to actually control and to take on that financial burden yourself, rather than spreading that risk across everyone and then paying a higher premium for all.
Makes sense. And then there's a couple more kind of get our bearings straight questions here, and then we can dive into the meat of this. You kind of talked about the fully insured versus self funded at the beginning. Do you have a sense of how popular one of these is versus the other? I'm sure there's statistics that we can look up that have a breakdown of what the percentages are.
Yeah, I mean, I think obviously the popularity will depend very much on the size of the group. And so increasingly popular. I think the bigger groups, it tends to be around 60 to 70% if you're looking at folks that have upwards of 5,000 employees. And so that has shifted a little bit. What we saw after COVID, of course, is that premiums went up in the fully insured space, and so a lot of folks made that transition to being self-insured because of those increased premiums. And I think it's correcting a little bit now. I think folks are kind of, especially the smaller employer groups, are going back to the traditional models, but they're also some employers are realizing that one of the added benefits of being self-funded is that you actually get access to claims. And with access to claims, obviously, you get much more insight on your patient population, on ways to actually adapt your plans to better tailor to the folks that you have, whether it's your employees or the dependents, right? The family members. But that access to claims is something that is unique about the self-funded model. And I think more and more employers are realizing the value of that data set.
Big detour here, I think, to talk about this because I think it's very interesting. Can you walk us through the scenarios in which, I think most people would assume that the employers are not getting access to claims? Can you walk us through the scenarios where they are getting access to the claims and how that data sharing actually works?
Typically, the reason that, employers don't get access to claims in the fully insured model is because that claims assessment is kind of the underlying data that is being used to assess the risk of the population, right? And in many ways, it's proprietary how these insurers are deciding what is a level of risk and how they're pricing premiums according to that level of risk, right? In self funding, you are the ones taking on that burden, and so you're entitled to the claims. Because you are the one paying for the claims. In the same way that if you were to swipe your credit card, you would be entitled to the data from your bank about where those financial transactions took place, right? But you're not entitled to someone else's. And so that's kind of simply where that breakdown happens. And then the employers themselves often are working with brokers actually to look at those claims, right? Employers, a big employer is not going to have actuaries on staff. And so that's where the self-funding model gets even more complex because there's a few other players that come into the mix to help really define what is a good plan for that employee population.
Very helpful. So let's get into the kind of nuts and bolts of this here. Let's say, as an employer, you've been buying off the shelf fully insured plans from Cigna, and you're interested in starting to go down this path of a self funded plan. Where would you typically start? Like where would you go to get help with something like this?
If you're an employer new to being self-funded, I think you'll definitely find yourself a broker to help you through the decision making, right? And at the beginning, you actually probably won't have a lot of data about your employees because you don't have access to that claims data. And so the first step, once you've decided that you're comfortable with the risk, is understanding who are the partners that you're going to take on this journey with. And those partners are typically going to be either the carriers or, third-party administrators, which tend to be smaller players that help you adjudicate claims. And it's also kind of who are the additional point solutions that you might leverage if you're looking to add some of these more nice to have benefits like fertility or mental health coverage, right? And so that's like, who are you using to deliver your health insurance, right? It's a very kind of foundational piece.
Can you
The
just give us a quick summary of what is a broker versus a TPA versus a carrier? What do each of them do?
Yeah. So a broker is going to be kind of your benefit consultant. They're the ones that are going to help you, and they do much more than just insurance, right? But they help you do your benefit strategy and they'll do things like 401ks as well as insurance, right? But the brokers are going to be the ones that have kind of that expertise on what are other peers of yours offering in terms of benefits, right? They'll help you benchmark against others in your area, others in your geography. They'll also be the ones that help connect you to the right partners that you'll use, whether those partners are payers or other kind of small point solutions. The carrier and TPA are very similar. Um, Typically, a TPA it stands for third party administrator, and these are going to be much smaller players that tend to allow for more customization in the plan designs than the carriers do themselves. In the self and I say that as a with an asterisk of it, because in the self-funded space, a carrier, Cigna has an in-house TPA. And so you're always kind of using a TPA, but they'll just vary in size and kind of flexibility. Um, yeah.
Yeah. So I like that. I think some analogies are helpful here. So if you think about kind of when you buy a plan on the exchange, kind of think about the exchange as your individual broker in a way, almost. It's like they're the ones helping you, guide through what to buy. Then you're buying the carrier is going to be your insurance company. So in this case, it'd be Cigna, and then Cigna is also acting as the administrator of that plan. So you can think about them as versus a third party administrator. They're a first party administrator, so administering the
Mhm.
plan. When you do fully insured, through a group plan, you're probably using some sort of a benefits broker. Then you're, again, using Cigna, and Cigna is the first party administrator there. And then it sounds like as you go into this world of self-funded, you're also using a benefits broker and they're helping you navigate instead of just, hey, here's the plan to buy, maybe they're starting to help you with some of the plan design parameters that you're thinking through. And you're going to select a third party administrator, which confusingly can be a third party or can be a third party administrator operated by the carriers themselves. Is that right?
Yeah, exactly.
Great. And now you come in, and at this point, is that the work that the broker is the broker's work finished at this point, and the TPA takes it from there, or how does the kind of multi-party negotiation work?
Yeah, I mean, no, I think the broker's work is just beginning, right? And then we really get to the meat of it and why we're here today, which is the plan design piece. And so once you've decided who you're going to go with, then begins really the intricate piece of designing your plans. And here there's a few things to think about. One of which I mentioned, which is the differentiation, but that's often the last thing that folks think about. And the first piece of the puzzle is, what are the plans that you want to offer to folks? What is the member experience that you're looking for your employees to have? And often that's dictated by your budget. It's also dictated by the demographics of your population. But really, what it comes down to is going to be things like, what type of plan are you offering? Are you offering a PPO, or are you offering a high deductible plan? Once you've made that decision, what is the deductible going to be like? What is the out of pocket max on your plan? Often that's going to be informed by your risk appetite, right? The bigger the out of pocket max, the less risk or less burden on the employer, and of course, more financial burden falls on the employees themselves. Um, and then the last piece of that is going to be kind of the cost share structure that you want to put into place. And what I mean by that is, what are folks going to pay when they go to the doctor's office? And so something like the deductible and the out of pocket max obviously play a role. But then there's also something as simple as the copay or the co-insurance, which is just a percentage of what you'll pay. All of that comes together to really form the plan design strategy. And typically what you see is employers will offer multiple plans. They won't just have one, right? And those plans will be differentiated on these different components of plan design. But outwardly, what the employee will feel is also the premiums that they're offered as, or that they have to pay. And so a more generous plan, something like a PPO, will typically have a lower deductible with a higher premium. So you pay more per month to kind of offset the cost of your spending throughout the year. Whereas an HSA, a high deductible plan, will kind of do the complete opposite, where you'll have a lower premium, so lower monthly payments, but you'll have to pay more upfront when you get care. And so then you really start to also put into play the kind of employees' care strategy and how much care they're looking to get. But having optionality is obviously good, especially if you have a larger employee population.
To keep things simple, if I, as an employer, know that I want to offer a PPO with a, a high deductible, and I'm pretty sure that that's what I'm looking for, and you have a pretty good sense of the broad shape of it. How does it work from that point, from like a very tactical standpoint? Like, does the broker or the TPA give me a worksheet to fill out where it says, "Hey, what do you want your copay to be?" And is there a standardized form for this? Is this everybody has their own unique process? Do they just give me a blank sheet of paper and say, have at it?
Yeah, I mean, if only it were that simple. I would say that there's probably a standardized set, right? Um, and that standardized set is going to be kind of what we think of as these high level benefit categories, right? And so, I previously worked at a TPA, and so what we typically gave was, as you said, a sheet, and we often kind of pre-populated that sheet with suggestions based on what are some standard plan designs, right? And then with the brokers themselves, you kind of workshop what are the elements that they care about. Say you're working with an employer who really wants to incentivize folks to get mental health care. Then you might look at, okay, how do I make that benefit specifically more generous than a normal physician office visit. And so you kind of start with a what I would say a templatized plan, and then you work from there based on your population.
So the way that might work is I come in and there's a pre-filled out worksheet that says, "Hey, we suggest generally a $20 copay and 20% coinsurance." And I might say, "Well, I really was hoping for a lower coinsurance than that, and this is great." And then there's probably another question that says, "Are there any categories that you'd want to treat differently?" And that's basically kind of think about that as, is there anything you want to incentivize or disincentivize?
Right.
And so from like an incentivized standpoint, that might mean, hey, I want um, nothing out of pocket for mental health. Is that roughly the way to think about it?
Yeah, exactly, exactly. Then you start kind of that incentive is that incentive structure is what we think of as steerage, and kind of you use, I would say, almost like traditional consumer principles to try to drive your employees to do something good, to behave kind of it in the way that you would want them to for the benefit of their health. Yeah.
And how detailed does this get? Is it that I'm going in and I'm saying, hey, when I want to disincentivize people from calling an ambulance versus taking an Uber?
Yeah, I think this is kind of where the crux of the challenge and the complexity of plan design comes into play is that in the past, I think plan designs were pretty straightforward. We thought of incentive structures as if I want someone to do something, I'll set it up as a copay. It'll be easy. They'll go get care. And if I want them to do it more than something else, then I'll lower the copay. And those were kind of the basic principles of plan design in the past. Increasingly, plan design is becoming more complex. There's more tiering involved, right? And what I mean by that is you start to get elements of preferred types of providers. And so, something that many of us are familiar with is this idea that if I go get an MRI at at the hospital after my doctor's appointment, I might pay $5,000. If I go get that same MRI down the road at a freestanding radiology clinic, I might pay $400. And so more and more you're actually seeing the incentive structure go beyond what we think of as the benefit category and start to bring in elements of who is the provider rendering that service, what is the place of service, where are you going for the care, and that's where things start to get really complicated, especially for a patient, right?
And when it comes down to it, and you've decided all these different parameters, how does this show up differently for the provider, if at all? So, if I have if I'm just starting with the basics of, does my insurance card look any different?
Yeah, the insurance card probably looks the same, right? Those fields are pretty standard. And so I think the where providers start to feel it is twofold. I think providers feel it in kind of the where patients are going. So the steerage effect, right? How many patients are coming to you, and then you also feel it in terms of how predictable, I would say, patient cash flow is, right? And what I mean by that is that as high deductible plans become more prevalent, then that's often associated with more bad debt, higher frequency of collections. Even you start to get kind of these complex patient payment plans. Um, Whereas if you have a simple copay plan, then of course you're kind of uh, much more easily able to do upfront collections. And so I think providers feel it much more on the plan design side than they do on the steerage, but both elements are relevant, of course, to their day to day.
Yeah, can you walk us just a little bit more detail of like an example of this collections process? So I walk into my doctor's office and, walk me through the difference of it's a really simple plan design where my copay is $20. What does that mean for collections versus something else? What's a more complex case?
Yeah, I mean, so I think we can walk through the same exact case, right? For someone who's on a high deductible plan versus a copay only plan. And so I think even if you walk in, say you're walking in for a strep test, right? And you walk into your doctor's office, you get a swab done, that swab gets sent off to a lab. At the end of that appointment, if you are on a copay based plan, the administrative office will look up your plan design. They'll see, great, $20 copay. That's that $20 that they collect up front. And they can feel pretty sure that that's the $20 that you will have to pay. And the rest will be actually billed to them by the insurance. Now, where things get a little bit more complicated is if you're on a high deductible plan, typically that means that you're having a co-insurance sit on top of that. And so all of a sudden, there are kind of two big things that you have to consider, which is how much progress a member has made on their deductible and what that co-insurance value is. And in order
Can
to
you
do
just
that,
explain quickly what what coinsurance is for people who might not be super? Most people know what a copay is.
so a co-insurance value is a percentage, and it will be typically subject to the deductible, meaning your plan will kick in once you've met your deductible, and then that co-insurance value will be applied to the remaining amount that you owe. And so, say you have a 10% co-insurance on your plan. If you go get care that is $500 and you've met your deductible, you'll pay 10% of that 500, so 50.
You got it. And then if you haven't met your deductible, you pay 100%, obviously,
Yeah, exactly.
until you've met it. Yeah. Yeah.
Exactly, exactly. So, when you go back to the original question, right? How does that kind of play a role in the collections process? The complexity is with the accumulators, you don't know where the patient will be on their accumulators.
Can
And
we
so
just dive into what accumulators are?
the accumulators that we typically think of are going to be your deductible and your out of pocket maximum. Your deductible, as I've mentioned, is kind of that amount that you need to meet in order for your insurance benefits to kick in. The out of pocket maximum is the most that you'll spend in a given plan year.
Great. And so if I'm thinking about, what the problem is for everybody to solve here, I walk into my doctor's office. Now they ask me for my insurance card. And on that, they see some static values. They see that the copay is $20 and then I have 20% co-insurance and it's a PPO. And so they have at least some reasonable indication that at some point I had a plan, in this shape. And I guess there's a few things that need to happen when I'm checking in. They need to make sure, is that card still accurate? Like, is my insurance still active, and do the values agree? So maybe it's the card from 2025, and now you're in 2026. Would be one example of that. And then the next is what you're talking about, which is these accumulator values, which is the dynamic values. So this the copay is not going to change. Copay is always going to be the copay. But as I make progress towards my deductible, like if I'm under the deductible amount, so if my deductible is $5,000 and I've spent $500 on my deductible, and for easy math, it's a $1,000 procedure with a 10% coinsurance. I'm going to have to pay the whole $1,000 because I'm under the deductible. And if that deductible were met, then I would owe $100. And so basically the fundamental problem to solve at the front desk, or before the patient comes in, is to figure out what are these dynamic values, and how much is the patient actually going to owe. And it sounds like your experience is that for the most part, they're just punting on that and saying,
Yeah.
"Well, we'll just see what we get paid, and then we'll go after the patient later."
Yeah, very much so. I mean, I think what you mentioned, the accumulator values, right, is a big one. And then there's also the layer of what the provider is actually going to bill on the claim. And typically medical billing is, I mean, you need a PhD to know how what combination of codes results in the right payment, right? And that's where there's this extra layer of kind of uh, complexity with the bill, and one of the reasons that the administrative offices don't try to predict what the payment will be. And what I mean by that, if we go back to kind of our strep example, you might think that a strep test would be a fairly straightforward thing to bill on a claim. There's probably one CPT code, so one of these medical billing codes that represents the strep test itself, and maybe there's another code in there thrown in for the physician's time, the doctor's time, and that's probably the two codes that you expect on that claim. But say that day I also had a headache, and I decided to ask my physician about this headache that I was feeling. He might decide that he's going to bill a more complicated office visit code, which means that the cost of that care automatically becomes more than what the administrator's office might have thought at the time of the appointment. And so, because of that uncertainty about what the physician will choose to bill for the combination of things that you discussed during your appointment and how that then translates to the actual cost of the care, the offices just say, you know what? It's simpler to just do it after the fact. Once it's gone through the electronic medical records, once the army of medical coders that we have kind of processed that conversation and decided the right combination of things. And so if we compare that to the copay example, obviously as a patient, it's a much less jarring experience to go and just to pay $20 up front than it is to be told, we won't know what the total cost of your care will be until after the fact, right?
Yeah, it's interesting because it's a problem for everybody. It's so all from the patient standpoint, you say, well, hey, it's frustrating. Why can't they just tell me what I'm gonna owe here up front? Um, but for the provider, it's also like, hey, we don't know what we're gonna get paid for this visit. Now, I think that it's more painful as a patient because it's more painful to not know what you're going to pay than not know what you're going to get paid. And a patient might go to the doctor once a month, hopefully, or less frequently, or get a procedure once a year. Whereas a provider is getting paid all the time. And so,
Yeah.
the lack of predictability kind of nets out. Yeah. It's interesting, that, the, you called, I think, the health insurance as a bit of a subscription in the beginning. It is different from car insurance in that your car insurance doesn't pay for oil changes and tire changes and refilling your gas, and is really for, if you get, everybody knows that your car insurance comes in when you get hit by somebody else or when you hit somebody else or when some freak accident happens. Very different from health insurance, which, as you put in, is more like a subscription plan where you're, it's like a membership where you're getting discounts and access to certain things. And it's like a rewards program almost, meets it's like a gym membership. The, but it's interesting in this where you have this dynamic, between the, employer who's offering the insurance as a benefit to the employee, and the provider who's rendering care, and the carrier, depending on whether it's self-funded or fully insured, um, who's responsible for paying. But then you've put the providers in this collections job, um, and sounds like a big burden on providers is just chasing down people for money.
So I think, Zach, it's a very great point. I think within hospitals, right, we would like to see providers focused on what they do best, which is delivering care. But the reality is that hospitals in the US are spending billions annually. It's one of their largest cost items, which is the administration side, which has fueled an industry that we know and are part of, at both Turquoise and Stedi, which is kind of the revenue cycle management side of things. And I think there's a lot of room for improvement in how we do revenue cycle management such that there's transparency on both sides, that physicians know upfront what they can expect to get paid and what they need to do in order to get paid that contractual rate, right? And on the patient side, uh, for patients to know upfront what they can expect to pay for care and not have to be on a copay based plan in order to have that guarantee.
Yeah, taking it back to plan design, it sounds like the biggest benefit of a really generous plan, maybe not the biggest benefit, but one of the big benefits of a really generous plan is that the employee never needs to think about anything other than a copay. And so you've got a $500 deductible or no deductible, you've got a $20 copay, and then you don't need to be thinking about coinsurance and all these different calculations that come into play. You know, uh, if somebody were to ask me, what does Stedi do? My response to this is often to tell them, well, when you walk into your doctor's office and they ask for your insurance card and they tell you your copay is $20 and you have 3 visits left, those transactions, which are called eligibility checks, are processed on Stedi's rails. Now, after the encounter and the claim is sent, we also process the claim. We process the claim status and claim acknowledgement and the electronic remittance advice, which is a record of what was paid. But it's often, to people who are not in the medical billing world, it's most obvious to think about, okay, that insurance card piece. Now, you have worked with Stedi and been very deep into our API functionality and know what we do and don't do. Maybe you could walk us through some of the challenges when you say, "Hey, Zach, well, it's nice to say that you say you return the copay, but what is the actual challenge and what does Turquoise fill in terms of gaps? What's the work that you had to do in order to get what Stedi returns from the payer to be something that the provider can use to say, hey, this is what you're going to pay today?"
Yeah. I mean, we've talked about how plan designs are getting increasingly complicated, right? And what that kind of layer that study provides is that translation between the payer and Turquoise about how to interpret the plan design and how the plan design is set up. But as plan designs get more complicated, there's exponential way that you can return the same set of information. And so what Turquoise has been working towards is figuring out how to actually consistently decipher what the payer is sending back in terms of coverage at different benefit levels and translate that to services rendered. Or so if we go back to the strep test, how does, you know, a service category on the study response translate to the two codes that I expect that strep test to be billed, and then the cost share. So whether it will be a co-insurance or a copay taken at by the or paid by the patient.
Yeah, it's I just rewatched a movie called Apollo 13. I don't know if you ever saw Apollo 13, but it's
Mm,
a wonderful movie, true story about the Apollo astronauts get lost, and there's this uh uh are stranded in space. And there's this problem where there's 3 astronauts who are confined to the lunar module, which was designed for 2 people for 2 days, and they're going to be 3 people for 5 days. And so one of the big problems they run into is that there's too much carbon dioxide that they're producing. And so what they end up having to do is you're probably wondering, where is this going? But I swear it comes back to what we're talking about. They have enough carbon dioxide scrubbers in the command module, but they're square and they don't fit into the round hole of the lunar module or vice versa. So what they have to do is they have to figure out how to build an adapter for the filter based only on what's on board, which is a couple extra spacesuits and duct tape and such. It's kind of a problem that happens in this same sort of impedance mismatch between what's actually needed by the provider and what's returned by the payer, and therefore is what's returned by Stedi. And you used a couple words there. I think you said service type codes, and you talked about CPT codes. Can you talk about the difference between, what is a CPT code? How is it used? Why is it needed? And then what on the other side is the Stedi is the payer via Stedi returning to you, and how do you have to reconcile those two pieces?
Yeah. If I've learned anything in my time in healthcare is that there's no shortage of acronyms in this industry, and I'm constantly learning new ones. But so CPT is probably the one that most listeners will be familiar with, right? We think of like CPT and HCPCS codes as being interchangeable. Simply, they're kind of the clinical billing codes that are sent on a claim. It's how providers translate the services that they delivered in an office setting into actually a billable unit. And the difference between that and a service type code is that the service type code is actually very specific to the eligibility checks that Stedi is doing, amongst others. And it's more high level. And so procedure codes are very granular. You'll have a procedure code that says, the excision of this 3 millimeter thing. It will be down to the specific patented drug. Um, a service type code is much more high level in that typically they're set at the what we almost call it or think of as benefit categories, which is you'll have a service type code for lab or a service type code for outpatient hospital. Now, obviously, then there's some kind of intricate mapping, and that's a mapping that we at Turquoise have done, which is what CPT codes equal labs and what are the conditions for those CPT codes to get billed and paid at the lab benefit or to hit maybe the outpatient hospital benefit, depending on where the care was done. Yeah.
So in a perfect world, the way this works is I go into my doctor's office and they said, okay, today you're going to have this mole removed and it's, such and such CPT code. And they send a programmatic eligibility check to the payer, and the payer comes back and says the patient owes $22.42 and you're going to get paid this much and everything. And in practice, that's not how it works. In practice, what actually happens is they say, well, for an inpatient procedure, if you're lucky, inpatient office visit, these are the general benefits that apply. You're going to get maybe the accumulators in terms of how much somebody's paid towards that general benefit category, but there's interpretation that needs to be done in order to figure out exactly what's going to get, how these things map. And it might be for Cigna, the CPT code maps to this one this service type code or benefit category, and for Aetna, it maps to a different one.
Yeah. Yeah, absolutely. And that kind of all that logic that's hidden behind the scenes, I think, is where you get a lot of frustration. I think both on the provider side and on the patient side, right? Providers also don't really have purview into what the payer will decide is the right benefit to apply. I think in a perfect world, we could kind of create these test claims and predict, right? And send a sample claim. Here's the combination of things I'm going to bill for this patient on this day and get a price back from the payers. But today that's really not how it works. And there's a lot of work that needs to be done to even get close to that accurate estimate.
So to tie things back, it sounds like there's a few components. So an employee, a patient goes into a doctor's office and they have their insurance card, which may or may not be current. The office needs to perform an eligibility check, and the data they get back is going to be missing the level of information they need in order to perform those calculations. And then I think there's one missing piece that we haven't talked about yet, which is the actual contracted rate. So it doesn't, this is not going to, the eligibility check is not going to say, hey, for this procedure code, this is how much we're going to pay you. Can you walk us through how that works?
Yeah, absolutely. I mean, the contracted rate really is the focus of what Turquoise has been doing, right? Which is, I think, Turquoise came about as a result of a lot of the price transparency regulations that started to require both hospitals and payers to publish these rates. But these rates were being published in what is known as a machine readable file. And as the name suggests, it's not meant to be read by humans. And so there's work that needs to be done for it to get into into a format where patients can actually take that information and even providers can take that information and gauge how much they should get paid, right? That those rates typically are rates that are going to be contracted between the hospital and the payers, right? And if we go back to one of the kind of original points about plan design, which is the idea of which partners do you use, which payers do you use, right? One of the benefits of going or choosing a payer is that the payer is going to be negotiating rates on behalf of you as an employer, as well as all of the other patients and employers that they cover. And that negotiated rate is what we think of as the rate. And we think of that as kind of the allowed amount on a claim, meaning the total amount that the provider will receive for the care that they delivered. And that allowed amount is actually the amount on top of which we then apply plan design. And so what I mean by that is, say a provider bills $1,000 for the strep test. They bill that to Cigna. Cigna says, actually, we are contracted for you to only receive $700 for that test. As a patient, you'll only have to worry about that $700 value. That's the value that your benefits will be applied to. So say you haven't met your deductible, you'll pay $700. The difference between those two values, you don't really have to think about as a patient.
It sounds like Turquoise is at the nexus of many of these pieces in terms of, figuring out the various impedance mismatches and tying these things together. Who would be a customer of Turquoise?
Yeah, I mean, uh, the reality is that Turquoise is serving a lot of the different stakeholders. Uh, there's value in that kind of end-to-end clarity for both payers, providers, but also employers, right? Employers want to understand what are some of, if we go back to some of the principles that we were talking about on steerage, employers also want to know what are the best networks for my employee populations? What are the best hospitals within those networks that I should be steering my employees towards? And so there's a lot of value in this data set for all the different players. There's just a different lens that each of them look at that data set with.
Very helpful. Um, well, let's wrap up with the closing question here, which was if you could change one single thing about revenue cycle management that wouldn't require a whole fundamental reworking of the system, what would it be and why?
Yeah. I think about this. I mean, this is basically what I do for a living. But for me, I mean, if I could just, wave a magic wand, it would be to try to start to eliminate all of these kind of hidden, the fine print in healthcare, right? Whether it's the little coding tricks or the benefit nuances or that kind of proprietary contract language that dictates how someone will get paid, but start to kind of turn that into a very simple, transparent price for the patient and for the provider, right? This idea of being able to guarantee prices up front. I think the value of that is twofold, right? I think for the patients, they kind of live in fear these days of the final price for care. And it's one of the only industries where you don't know what you're going to pay up front. It's always kind of a surprise bill at the end. And I think that certainly needs to change. But I think, like we've mentioned, providers, there's so much value in providers dedicating their time and to care, right? And to improving the health of our population rather than the administration. And so I think for me, uh, it's kind of moving towards this standardized, transparent, almost like a quote and bill model that you see in other industries, rather than something that happens behind the scenes. Yeah.
Yeah, sunlight is the best disinfectant, as they say.
Yeah.
Well, thank you so much for coming on the show today. It was fascinating to ask these questions and be able to ramp up on the various pieces of plan design and how this actually fits into the picture of working with providers as a patient. So, thanks for coming on.
Of course. It was my pleasure. Always happy to talk about plan design.